SSRIs and weight gain. So we have two objectives. I'm going to try to very briefly within the didactic blitz describe the rationale for why some of the selective serotonin reuptake inhibitors cause weight gain, and then compare the data on the SSRIs and weight gain. And I've split it up, both looking acute, so 12 weeks or less of treatment, and for patients who are taking it for longer than 12 weeks for chronic treatment. And you'll see why in just a little bit. But before we get started, I wanted to define weight gain. So the definition of weight gain in the literature is pretty broad. So we're gonna use the broadest umbrella that I could find. So it really fell into two buckets. So one was any change in weight from baseline. So if there was any type of elevation in weight causing weight gain, even if it may have been just a normal fluctuation in weight, that did get lumped into weight gain for some of the trials. For some of the other ones, we did try to focus on more clinically significant weight gain, and this is considered an increase of greater than or equal to 7% of body weight from baseline. So if a patient is putting on that much weight, it really is considered clinically significant. Although for some individuals, it may be significant enough less than that threshold where they're having to move clothing sizes, or they actually can feel the difference of that weight gain, but that's the one that was defined in the literature. So you will see both of those being used. All right, so jumping in, SSRIs and weight gain. So how might we see weight gain in patients who are on selective serotonin reuptake inhibitors? We're not sure. One of the considerations is if the SSRIs are working, some of the depression symptoms could be loss of appetite. So by resolving the depression symptoms, a patient gets their appetite back and may therefore put weight back on. Absolutely plausible. The one thing I will point out though is when we look at some of the evidence, it's not consistent with all of the antidepressants. So if we see consistent efficacy with the antidepressants where we would expect about 2/3 of the patients to be responding in their depression symptoms, then we should see a similar change in weight for those 2/3 of patients, and that's not what happens. So maybe this plays a bit of a role for some patients. Your atypical depression patients would be in the opposite direction because they might be overeating. So maybe this is only a little piece of the puzzle. Comorbid conditions. So it is recognized that 2 to 3 times, obesity is 2 to 3 times more common in patients with mental health conditions. So maybe their lifestyle is a lifestyle that may put them at risk for continuing to increase weight. Again, a plausible rationale for why we do see weight gain, but it wouldn't explain some of the differences that we see with the medications. So I'm going to push those into the background a little bit. The two pieces I want to focus on are really the actions of the SSRIs. So SSRIs increase the amount of serotonin that's available. So between the neurons in your brain, they're going to block the pumps that take the serotonin back up, and serotonin's more freely available. Interestingly, serotonin itself is really thought to be an appetite suppressant overall in the brain. So that seems a little bit counterintuitive, so we have to dig a smidge deeper. If there's more serotonin out there, there are a whole bunch of different serotonin receptors. Some of the serotonin receptors are on the presynaptic side of the neuron. So they're on the neuron that's sending the message. When serotonin's out there and it works on those receptors, it may stop those receptors from releasing more serotonin. So it may actually cause a decrease in serotonin. If serotonin's an appetite suppressant and we decrease it, then that may mean that the appetite goes up a little bit. Other things that can happen is some of those receptors that help with the appetite suppression that are on the postsynaptic side, they keep getting stimulated because there's extra serotonin that's available. So it's possible that they get downregulated, that the neuron goes out and says, you know what, you're constantly sending messages, maybe we don't need quite as many of you, and actually decreases the number of serotonin receptors that are there. That may diminish the amount of serotonergic signal that gets passed from one neuron to another. So that appetite suppressant effect may actually be lower than what we would have anticipated. Now, this would take some time to occur. Other things that can happen with serotonin, serotonin plays a pretty significant role with other neuropeptides and with hormones. So it appears that some of the serotonergic neurons actually may influence the amount of leptin that's available, which could directly impact a patient's appetite. It can also impact a number of other neurotransmitters, which I'm only going to hit on briefly. So melanocortin-4 receptors actually can curb appetite. So sometimes when we have those serotonin signals, this can activate that pathway so much that we get a downregulation and it stops activating that pathway. So another hormone, another set of chemicals we have in the brain that are supposed to be suppressing our appetite now aren't working quite to the same level that they had been previously. And that's true of a couple other pathways as well. So not a clear, consistent answer, but it does look like there's an interplay both from the serotonin itself, as well as from serotonin's effect on some of the other hormones and neurotransmitters that we have. So relatively complicated, and just to get this out there, there's a huge amount of interpatient variability. There look to be some genetic indicators that would increase or decrease your risk for developing weight gain when you're on one of the antidepressants, although they're not specific. So just because you have this particular code doesn't mean you definitely gain weight, but you're just at a higher risk of doing so. So let's look at the data. How much weight are we talking about and what happens? We're going to start short term. So when we first start antidepressants, this is about the first 4 to 12 weeks. So really the acute phase of treatment. I didn't pull all of the individual literature. There's a couple really well done review and meta-analysis that did pull the data, and that's where a lot of this comes from. So of the SSRIs, you see the distribution of trials that were included in this meta-analysis. So fluoxetine by far had the most, paroxetine and sertraline kind of the next, and then citalopram, escitalopram, and fluvoxamine. One point I did just want to make, these trials did include both patients with depression as well as patients with different anxiety disorders. And one of the escitalopram trials included patients with somatoform disorder. So it wasn't just for affective disorders, it was just the use of SSRIs in general. So what did they find? So this was pooling the number of cases or patients that were on the SSRI. Controls are the patients that were on the placebo. And then the mean difference is that difference in weight in kilograms that they saw between those two groups. As you can see, with the exception of fluvoxamine, most of the patients had a weight loss in the acute treatment phase. So those first 12 weeks. So that runs a little bit counter to what I just told you. 2 reasons that this may occur. Number one, serotonin is an appetite suppressant. So as we acutely increase the amount of serotonin, we may see that amount of that action of appetite suppression. The second reason is when we first start, easy for me to say, the SSRIs, patients can have a lot of GI side effects, nausea, vomiting, diarrhea. They may not want to eat, and that may result in some of the weight gain as well, or weight loss, excuse me, as well. The amount of weight loss, though, is really relatively modest. So we're talking about a ½ pound to 2 pounds in this 4 to 12 week time frame. So in just looking at this overall, it looks like, at least at first, we're not going to see any weight gain effects. And this is looking at it just a little bit in a different format. So this is the mean weight change on the y-axis, and then it has a few other antidepressants on the x-axis. As you look at our SSRIs, they're a little bit closer to the left-hand side. So you do see a little bit of that weight loss with this group relatively consistently. So even when you look at it a little bit of a different way, we do see a little bit of that weight loss. Now, what about more long-term? So this was the same meta-analysis, and it pooled data from 4 months of treatment and longer. And in some cases, I believe it went up to either 18 or 24 months. So not super, super long-term, but longer term. As you see, we have significantly fewer trials here. They did include both depression and anxiety trials. I put the little star next to the fluvoxamine because there were 2 anxiety trials that they identified, but then they didn't give us the data for them. And I was trying to pull them, but I didn't get as far as I needed to. So we don't have that data. When they looked at these SSRIs, again, cases are patients who are on the drug, controls were patients that were on the placebo. We do see not as much of the weight loss. The fluoxetine and sertraline, even though they had a little bit of weight loss, it was not considered significant because it does include that 0. So potentially nothing happened to their weight. But we start to see signals of weight gain with the citalopram as well as with the paroxetine. So the paroxetine was the only one that was statistically significant when they pooled the data. There was a lot of variability in the trial, so that might be part of the reason we didn't see much of a difference there. But that difference in more than 4 months of treatment was more than 6 pounds of a weight gain for those patients. So probably enough that they would notice this. So again, in looking at this, we do see some, in some of these trials were 6-month trials, we see some of the SSRIs, fluoxetine and sertraline, maybe didn't have as much of an effect, but some of the other agents do suggest that maybe there is a trend for some weight gain the longer patients are on treatment. So I did a little bit more digging on the chronic side. So this was a cross-sectional study that was done, it was published a few years ago. Outpatients that were adults that were on SSRIs, so a little more than 350 of them. The patients had been on SSRIs between 6 months and 36 months. So up to 3 years, which is a little bit longer than the trials that were included in that previous meta-analysis. So most of these patients, the average age was the early 40s. Most of them were women. But when we look at this, we find that, so they gave us data for citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. So again, fluvoxamine didn't have, wasn't included in this. We see the number of patients that were reported to have weight gain. So from baseline as they followed them, more than half for citalopram, escitalopram, and paroxetine. Not quite as much, about 1/3 of the patients on sertraline and about 15% of the patients that were on fluoxetine had some weight gain. The ones that had that clinically significant weight gain, the escitalopram and the paroxetine were right around 50% or just over 50%. So half of those patients were having clinically significant weight gain. And then even more striking is they had about 10% of those patients gained more than 20% of their baseline body weight while they were on the antidepressant. So that's interesting because these patients had even been on these SSRIs for 6 months when they started the trial. So there is a small portion of these patients that do look like they gain a significant amount of weight. And there were no other, they excluded patients that were on mood stabilizers or antipsychotics. So they really didn't want them on other medications that we know can increase weight. So trying to find other data that really compared how much weight gain, because that's quite a bit of variability. 15% of those patients with fluoxetine, and that was the lowest percent, still had some weight gain, up to almost 75, 3/4 of the patients that were on the paroxetine. So I found this trial. So this was a different systematic review. And you can see they had a significant number, thousands of patients for each of these. And this is the percentage of patients with more than 7% weight gain from their baseline. And our SSRIs, fluoxetine and sertraline, which had looked good before, added to the citalopram and escitalopram and paroxetine, all of them had more than 15% of those patients gain a clinically significant amount of weight. So there definitely looks to be a portion of patients who are on the SSRIs longer term that will start gaining weight. So why is this an issue? Well, a couple reasons. One, there can be other comorbid conditions. So as I mentioned in the beginning, obesity may be a risk factor in a couple directions for depression, but that could also increase the risk for other other medical conditions. So patients who are obese, potentially starting to move down the direction of metabolic syndrome with hypertension, development of diabetes, maybe hyperlipidemia. So that could be problematic for them. And maybe the more conditions they have, that might have an impact on their depression and whether or not they can continue or need to continue with their antidepressant. And another big concern is with that weight gain, that may have a direct impact on adherence. Patients are notoriously non-adherent long-term to antidepressant medications. Long-term reasons for discontinuation tend to be sexual dysfunction as well as weight gain. So once the depression symptoms have resolved, those two seem to be standout adverse effects that patients aren't willing to tolerate long-term, which may put a patient at risk for exacerbation of their depression. So to wrap up, the mechanism isn't entirely clear for why weight changes with the SSRIs. It does look like serotonin plays a direct role in maybe the downregulation and the regulation of other hormones and neuropeptides are involved. Acutely, patients may experience weight loss, but long-term treatment does appear to result in clinically significant weight gain for a small portion of the patients. So something that would be important for them to be aware of, and maybe from an educational standpoint, having them aware of and working on lifestyle modifications, physical activity, which could help with their depressive symptoms, as well as their diet to try to stave off this before it starts to occur. With that, I'm going to stop and I will turn it back over.
Thank you very much, Sarah. So questions, comments about Sarah's presentation or any of the content?
Usually they say that the, like Wellbutrin, the SNRIs don't have weight gain, but there was one chart there that looked like there was. So if you had to pick for a patient, what would you choose?
So that's a good question. So bupropion tends to have the least amount of weight gain reported. And if you think about comorbid conditions and lifestyle factors, as well as maybe improvement in the depressive symptoms, that might be some of the weight gain we see with the bupropion, but overall that does not appear to have significant weight gain as some of the other agents. The SNRIs are interesting. So I've seen data in both directions where it doesn't seem to have as much an effect on weight and where it does. And I believe that part of that may be related to the dose that's being used. So in some cases, it may be more serotonergic. And in other cases, if we push the dose higher, you might get noradrenergic effects as well as dopaminergic effects. And it was just one of the papers that I looked at. Those that had the higher doses didn't seem to have as much of the weight gain long term, but I think the data was only like 9 or 12 months, so it didn't go out really long term. So I think the risk is still there with the SNRIs, but it may not be quite as much as we see with just the pure SSRIs, or at least the data is not as consistent. That's a great question, Dr. Betts. Thank you.
Amy Lacris, I saw that you had a question too.
Data in the pediatric population, is there anything that extrapolates, or have you seen anything there where weight gain in, kids can sometimes be an issue in so many ways?
So that's a good question, and I did try to do a little bit of looking. I couldn't find any of the nicer overviews as much for the pediatric population, but there are reports of weight gain with the SSRIs in the population. And actually what I saw was, even though fluoxetine in adults looks like maybe it's not as significant with the weight gain, and maybe it's because there's more data, it did look like there was weight gain reported in pediatric and adolescent patients, even with the sertraline, paroxetine, and fluoxetine were the 3 that I saw. The amounts, it depended on the patient population, but in some cases it was up to the upper teens reporting some increase in weight, but a lot of those were just changed from baseline. So if the kids are growing, their weight might go up anyways, and that was a confounder that was noted. So something for them to be aware of, but it wasn't quite as clear. And I did just want to, Julie, yes, the Wellbutrin, one of the reasons that one looks to be more advantageous is because it works primarily on dopamine. It doesn't really have those serotonergic effects, and that's likely why we see that differentiate from the SSRIs and SNRIs. So good point, thank you.
A question for you, Sarah. For those who've been on medication for a long time, is there any ability, like, can a patient get to a situation where there's just no way to that's completely changed their metabolism and that they can no longer go back? There's some research that's out there talking about progesterone for patients who are taking that for mood stabilization. Obviously, it's a hormone-based type of thing, but that it was having a huge impact on actually changing a teenager's metabolism to like that of my age, where you hang on to all the fat and all that good stuff. So how do all these things apply? Is there any, we often get patients who are just like, well, that's just the way it is. I guess I'm just gonna have to deal with it. What we can do to encourage them that there's options that can improve this.
So that's a great question, Jen. I did not come across anything. The research that I found that was looking at those different pathways was looking more at what are the impacts that we see on all of these levels, not are they long-term. Like if we pull the drug away, does that go back? Some of the acute effects do look to be reversed, because it was they did some lab style challenges, like when they use different serotonergic agents or blockers, but I didn't come across anything long-term. That's an interesting point.
That was something that did come up quite a bit, especially when I was at the hospital and I had individuals on medication for long term, and constant battle, because to stay on the medication and to be to feel good about yourself, or to not have depression or anxiety. It was always this balance in their mind, and that's what created a lot of not following through with doctor's orders because of that. So
well, and I think about that, I don't know as much about some of those neurohormones that they were in, neuropeptides that they were talking about, but when you think about things like kids on antipsychotics, so like if we have elevated prolactin and their hormone levels are low, I mean, there are long-term potential ramifications. So they may not have women may not have the protective effects of estrogen, so they may be at higher risk for cardiovascular disease, for things like breast cancer. They might be at higher risk for earlier osteopenia and osteoporosis. So what may changing the exposure levels of these things like neuropeptide Y and the MCR4, like what might that do to their metabolism long-term? That's intriguing, and that could have massive ramifications for how long patients stay on drugs. Dr. Getz, have you come across anything related to that?
I mean, with kids? No, I find that about half of them, it's usually the girls gain some weight, but generally not the boys. But there's always resistance to taking it very long.
Randy, did you have a question or comment?
Yeah, I was, but it was just, if one of the things that surprised me the most from the data you were presenting was the data on escitalopram, because kind of clinical lore is that it's so much better than regular citalopram, and that, you know, and that's why it's more expensive and all that kind of stuff. But at least from the data you were saying, it was at least as weight gain was at least as prominent with the escitalopram as it was with regular citalopram. I just thought that was really interesting.
It was in that cross-sectional study. I was shocked. I was shocked at how much weight gain they were reporting in the patients that were on the escitalopram.
It doesn't whatever, Lexapro become Celexa right away? Isn't it metabolized that right away? So it really is just a more expensive form of Celexa?
Similar, so it's an enantiomer. So you have two different versions. So the citalopram has both versions and the escitalopram is just the one version. So the thought was by kind of only having that one, let's say cleaned up product, that generally the consensus is, well, maybe that's better tolerated because we're just focusing on the part that's supposed to be active. But that wasn't what they found. And even in those few trials that they included long-term, they still saw some effect on weight. So I think that maybe the perception and what the data says might be a little bit discrepant for that. And it's not as different from the other agents. I just wanted to point out to Julie's point, absolutely making sure that that medical workup is done for those patients is really vital. And I think this was a great example of making sure that we're paying attention to those medical things, thyroid issues and diabetes and all of those other things, because they may have quite a significant relationship with some of those depression symptoms and maybe even with the treatment that we're using for those.
I think it's also fair, and you kind of referenced this, but there are very few patients where increasing activity and exercise would not be an appropriate recommendation to make, no matter what else you're doing for their depression. To say, you know, there are some who physically can't do it. I got that, but for the vast majority, let's get you more active. That is a general recommendation for a lot of different reasons. Should be something we do kind of automatically, and very often we don't.
So I saw that Pat had put something in about transcranial stimulation and one of her patients, but I see that she's walked away from her computer for a moment. So does anybody else have questions about the SSRIs or this presentation before we jump into that?
I just had another comment, and that is the impact of poor sleep on poor eating habits. So that's really well documented as well. So we really want to pay attention to if our patients are sleeping. So that could be a part of weight gain for sure.
And the depression.
Yeah, thank you, Barb. Amy?
Oh, I was just going to say that the poor sleep will contribute also to the depression. So, you know, so many factors coming in. So.
Sarah,
Absolutely. Sleep is critical.
Sarah, do we know what the average weight gain in the population is over X period of time in recent years? I think the gradual weight gain in the population in general has been relatively well noted, and that the addition of the SSRI is just adding a little bit of fuel to the flames of excess eating.
Bob, I'm glad that you asked that, and I have to shout out.
Oh, you're very welcome, Sarah. I'm really glad to.
I looked at this because I thought Dr. Ballister was going to ask me this. For the record, so the data that I found was a couple years old, and what they saw was there was a little bit of an average, but about a 2 to 3 pound weight gain over time in the general population. So there were definitely outliers on both sides, people that lost a significant amount of weight and people that gained a significant amount of weight. But they saw that on average, the yearly creep was about 2 to 3 pounds. So as they were looking at people, there was definitely variations throughout the times of the year, but the overall average was continuing to go up, although it looked like it was leveling off. And I don't remember if the last data was 2017 or 2018. I didn't write that down. But so a little bit of that increase, so not enough to be that 7% change in baseline, but that adds up pretty quickly. And again, the call out for all of those lifestyle modifications, it'd be good for all of us.
Yeah, that is the truth. Amy?
But on the flip side of all of this, I mean, on top of the, you know, sometimes resistance people, I know, you know, a lot of my patients have had, oh, no medication. The vast majority of the people don't gain weight and do well on the medication. So, you know, we can, although 15% give or take is not insignificant, it's still the majority do well. And just have to always, you know, kind of remember that.
Right, half gained weight, but half did not. Absolutely, that benefit of the antidepressant is not something to be frowned upon. You're right.
All very good points. So, Patricia, do you want to tell us about the comment that you put into the box?
Yeah, I had a 18, almost 19-year-old who's got autism and threatens his family to harm them, though he's never done anything. And we're actually getting some respite for him. But his mother called and said that she had been approached by somebody that does the transcranial electrical stimulation called Nexalin for depression. And that's all I could find it for. But then there's also transcranial magnetic stimulation. Being a child psychiatrist, I'm not familiar with either one. And I was hoping maybe the adult psychiatrist could tell me. Now, the mother was told that the Nexalin could cure autism, which seems pretty out there. But you guys tell me what you know about these two interventions.
Great question, and I am looking to all of the people that are much more qualified to speak to this in this room than I am.
I haven't had too many patients that have used that, but there are reports of that being used in patients with attention deficit disorder, with autism, spectrum disorders, as well as with refractory depression and obsessive compulsive disorders. The literature that I saw was more on symptom improvement, and it did improve some of the symptoms, but most of them were case series. I see Julie's cure there. So there is some evidence to suggest that it will help improve some of the symptoms, but I haven't seen anything that would suggest that it will remove most of them.
And I think we need to identify the difference between them too. So transcranial electric stimulation, the direct current stuff you can buy on Amazon.com. I mean, you can just go buy these little scalp things, and they were started off, I think as Sarah was talking about, as aids to improve concentration, usually temporarily. There was some work in the military looking at that. And you know, he stimulated them electronically. They remembered things better, learned things more quickly. I've not seen really well-designed studies. Maybe they're out there and I just haven't seen them. On the other hand, TMS, the transmagnetic stimulation, has been studied. It's initially treatment-resistant depression was its primary thing. It's also been looked at in PTSD and a number of other kind of conditions. And that one is you know, you're going into an office. It's a very controlled kind of procedure. But you walk in the office, and you know, a half hour later you're walking out of the office. It's not like ECT. So what I suspect they were talking about is that transcranial electrical stimulation, the direct current stimulation, that is being pushed a lot now for, you know, help your student do better by giving them this little electric cap to wear at night. I don't know that it's been rigorously studied though. And maybe others can correct me.
Yeah, this family was told they had to pay $5,000 to have this done by someplace in North Carolina.
Ooh.
Yeah. Okay.
I just included in the chat just a NCBI article from 2015, and their conclusion right now, so everybody has that, is just that there's just not enough large-scale controlled trials right at this time to show that. And it's also, you know, this is an aside, but it's also become quite controversial, you know, and tying in a lot of different things. Coming from the autism community, there are those who, you know, can be offended if they consider a cure, but there's also certain particular aspects of autism that could be helpful. So, you know, but this article might help, you know, I sent it in there for everybody to see.
Thanks. And Laura had a comment also.
Oh, just on the Nexalin or the electrical stimulation, I know that's made waves in the Amish community as a cure-all, and they tend to latch on to natural alternative cures, and a lot of times it is money makers for people that aren't well vetted. So I have a heavy degree of skepticism about that particular therapy, especially since it's been touted to cure a lot of things, and different Amish people will become providers for it and then offer it as a money.
Actually, this was an Amish family.
There's another interesting thing, and I don't know, maybe Randy could speak to this, but I know of a case where there was someone who was really struggling with OCD, and they just pulled in some of that type of therapy into Columbus there. I don't know if it's which hospital is sponsoring it, but it's research-based. And, you know, and so that's something that's forthcoming. But I don't know which one it's differentiating, what treatment format that was, but it did involve magnetic aspects to it.
I haven't heard. I would guess that would be the TMS, which is the transcranial magnetic stimulation, but I haven't heard. I don't know anything else about it.
So Barb, I saw your question. I don't know about
You heard of it, Sarah?
I don't know about the electrical stimulation, but I know they have done, I'm trying to see if I can find the article, with the TMS for some of the less med responsive anxiety disorders. OCD and PTSD came to mind. I don't think there's a lot of trials, but there are a few trials where they have used it in patients that didn't respond to medications.
So thanks to everyone who continues to put great resources into the chat box. And go ahead, Doug.
Sorry, I had to drive from one point to the other, so I switched to my phone. But if a local resource would be the SUMA system. They actually do ECT, but they also do the RTMS. So if you're interested, we may be able to get more information from them in terms of what exactly they treat. They're going to go by the book of whatever has been actually researched enough to treat it. So I know they at least do depression. I believe they also started doing OCD, as I think Sarah mentioned, that's also in the list of things. So I'm happy to reach out if that would be helpful to you.
I'm trying to type suggestions as people are sharing them. Thank you, Doug. I think that would be helpful, just to get a list of what are the things that they would be willing to consider for using those treatment methods, and what are the diagnoses or disorders that they're saying, you know what, there's not enough evidence, so we're not going to do it.
Exactly.
That'd be good.
And it also wouldn't be a $5,000 out-of-pocket expense, which would be a lot more feasible for most patients. So.
Yeah, if this was a valid treatment for whatever the particular disorder is, I'm sure that it could be done closer, cheaper, and under better guidance than we can guarantee for whatever is going on in South Carolina. So we still have about 12 minutes left. I don't know if people have additional thoughts or comments around this particular topic, or any updates that they would like to share, or some feedback that they'd like. I'm trying to open the floor though. Whatever is most helpful to everyone. Okay, I see Bob's unmuting.
I've been asked kind of socially in multiple settings recently, mostly in phone conversation and the Zoom conversation, whether they think the COVID period has added a significant amount of depressive qualities to people's lives. And there are multiple newspaper articles about this, but on a day-to-day practicum of chatting with people, I don't really have a hard number that's available in the community. I wondered what other people are thinking or casually chatting about when asked these things.
I don't necessarily have, yeah, it really is. I don't necessarily have any studies, but I know that we get our numbers every day for our various departments in Coleman, and our crisis center is hitting 130% of their goal. And so I want to say that, especially because we just did our fiscal year to kind of adjust and bump those numbers, that if we're, I guess, overreaching our goal, that means that there are a lot of people, and those are just the people that are reaching out to our 24/7 resources. I know personally too, this is anecdotal, but my clients continuously talk about how the last couple months have been really rough. And so I've noticed an increase in symptoms where I'm recognizing it, and then also my clients are recognizing it.
I have quite a few people of color, and I would say the pandemic of awareness of racism is creating a huge issue for those patients. There's a lot of desperation and fear about democracy, and so I am seeing that a lot, and I can't imagine what it's like for the therapists to be, untangling that and really working with it, because people are really in despair about it.
I think as a, oh.
No, go ahead.
Oh,
Yeah,
I was thinking, as a team here at NEOMED, we are particularly concerned with not only the pressures that our student population are under, but also the generation that's coming in. It's not completely majority based, but there just seems thematically that there's a need for really focusing on distress tolerance skills and building. And we're we're already thinking and kind of terrified to go for the next 3 months to see how things build here, with just not only a very stressful environment, but then also our societal environment and the pressures that are going on there. We're kind of already got our strategy in place